Hello, and welcome to Attention Deficit Hyperactivity Disorder and Athletic Training Clinical Practice, an EBP approach. Our presenter today is Elizabeth Wolfe, CAGS ATC. Ms. Beth Wolfe is the Injury Prevention Coordinator and Research Assistant for the Division of Trauma and Acute Care Surgery at Tufts Medical Center in Boston, Mass. Ms. Wolfe completed her undergraduate degree at the University of South Carolina and her master's and certificate of advanced graduate study at Boston University. Currently, Wolfe is pursuing her doctorate of health science in healthcare administration and leadership from MSc-PHS University. Within Massachusetts and the greater Boston area, Ms. Wolfe is a collaborator and lead author on numerous injury prevention projects and coalitions that revolve around road safety, fall prevention, and brain trauma and concussion prevention. Ms. Wolfe is an active member of the National Athletic Trainers Association and is the District 1 Young Professionals Committee representative and the treasurer for the Athletic Trainers of Massachusetts. You'll see the evaluation and assessment forms found on the lecture page. Please download these, fill them out, and return them to me at mhunt@precisionat.com. When I receive these, I will then email you the statement of credit for the course. If you have any questions, comments, or concerns, please email me or call me at 781-366-1880. Without further ado, Beth Wolfe.
All right, let me just move this laptop up here a little bit. Okay, my name is Beth. I'm very happy to be here. This topic is very close to my heart, and hopefully it's going to be very entertaining. I know that psychology can be a very dry subject, and I tried to make this a little bit more interesting and not like a lecture that you had in undergrad about just general psychology. But first and foremost, I don't have anything to disclose. I'm not getting paid by outside people to be here. The information from this presentation, though, is going to be important for your clinical practice, but if you have a team physician or a psychologist or psychiatrist that you're working with to care for your patients, their advice is going to oversee anything that you're going to hear here, because obviously they are very well trained and licensed in what they do. And if they tell you to make accommodations for patients, please heed their advice and not necessarily these evidence-based guidelines. The objectives you probably have seen in the advertisements. I'm going to go through them very quickly because I don't want to mundane the point. But you're going to be able to describe the current Diagnostic and Statistical Manual 5, so DSM, the behaviors and characteristics of ADHD. You're going to be able to recognize that your patients may not fit within the cultural norms of everyone else in your group, but that doesn't mean that they're not capable, and it doesn't mean that they shouldn't be treated any differently. You're going to be able to describe, conduct, and develop an alternative treatment plan and condition with accommodations within your athletic training facility to make sure that your ADHD patients can thrive in an environment that's not made for them. We're going to talk about that a lot. You're going to be able to create a list of questions that you can talk with your medical directors or your psychologist to make sure that your athletes and patients are getting the best care that they need. Because every single person is different. Their symptoms are going to be different. We're going to talk a lot about it. You're going to be able to advise, instruct, and support your patients in becoming autonomous in their health care via some techniques we're going to talk about in sports psychology. There are many different aspects. We're only going to focus on self-determination theory and self-directed learning. We're only going to focus on two. We're not going to go the whole gamut. But you're going to become an advocate and an agent of change in the current athletic training environment by modifying your practices to fit these patients. There are a lot of other things I think you're really going to like about this presentation because it's going to challenge our culture and what we've been trained to do since the inception of our profession, and how we've now grown to know a lot more about psychological disorders and diseases, and mental health is coming to the forefront right now in our society. And this issue is just the tip of the iceberg. So I just come with this with an open mind. If you get overwhelmed, it's okay. I'm more than welcome to talk after or email or anything like that. So agenda, what is ADHD? We're going to talk about that. And who are these patients? And you notice I put everyone in this square box. In athletic training and in science and medicine, we like to put people into categories. We like to describe them by check boxes. We like to put everyone in a box. So we're going to talk about the ADHD box. And this little pentagon is the myths around ADHD and what we think it is, but actually what it's not and what it could be. We're going to talk about that. And then this nice little circle is our athletic training culture and environment. We like our circle. It's full of people like that are in this room that we all have common beliefs, but yet at the same time, we don't really like people that don't fit our mold very well. And we're gonna discuss that. And what do we get? Houston, we have a problem. We can't fit a square peg in a round hole. And that's the whole purpose of this presentation, is we're gonna talk about why do we put our patients into boxes when they don't really need to be. So first off, I hope everyone can see this chart very nicely. In order to diagnose ADHD, it's not a one-time visit to the doctor. This is actually a 6-month process or longer. So that's why it's important for ADHD to be diagnosed so early on in life, hopefully within the first couple of years of school. But we'll talk about this a little bit more, that sometimes our patients have maybe never been diagnosed. And even as adults, we've never been tested or diagnosed either. But a few of the classifications from the DSM-5, there are 3 big categories for ADHD. Number 1 is inattention. Number 2 is hyperactivity. And number 3 is impulsivity. And you'll see there's a little hyphen there for hyperactivity and impulsivity, is because those usually go hand in hand. But yet there's still 3 separate entities. And for children, you can kind of read a little bit more, but for children, there's usually an academic impact that this disorder is having on them. So either they can't sit still in a chair, or they're having some other difficulties with their academics. And for adults, they're classifying as 17 and older. They need to have several symptoms, just as like children, but usually it's 5 or more symptoms for adults, and usually around 6 or more for children. And the severe inattentive and hyperactivity symptoms are usually present prior to age 12. So if you have a kid that's 5 years old and is bouncing off the walls and is quote unquote a behavior problem, we'll talk about that, behavior problems. Those are usually the kids that get flagged for ADHD. But there's also some other symptoms we'll talk about on the next slide that may or may not fall into your preview of classic ADHD. These symptoms can be present at home, school, athletics, work. They can be present everywhere. So it's not just one setting. And I think for most of us, we think of ADHD only in a classroom setting, just because that's where we learn. That's where we have to focus. That's where we have to sit still. But in athletics, it's no different. It's the same setting. So I think that's pretty much it. There's a few other bullets, but I want to move on to the next slide, and let's really dig into the signs and symptoms. I think it's really important that we actually go through each one. I'm not going to spend a lot of time, but on the left-hand side, we have signs of inattention. And the basic signs and symptoms of inattention are fail to give close attention to detail and make mistakes. So if you can't trust either an athlete or a patient to do a task correctly, make sure that they do every single item on a list, then that's a sign and symptom. Often has difficulty sustaining attention on tasks and activities, does not seem to listen when spoken to directly, so the words go in one ear and it goes out the other. Does not follow through on instructions and fails to finish schoolwork or workplace duties. Often has difficulty organizing tasks and activities, avoids and dislikes or is reluctant to engage in tasks that require a lot of effort, especially mental effort. And that's why a lot of times patients with ADHD, if they know that there's a homework assignment or a big term paper, not only do they wait to the last minute, a lot of them don't do it, is because they can't. And these symptoms prohibit them from doing that. They often lose necessary things. How many of us lose our car keys every day? Not gonna lie. So that's one sign and symptom, that they lose everything. And as soon as they're about to walk out the door to go to class or whatever, it's like, oh my goodness, I'm forgetting everything. They're easily distracted by extraneous stimuli. They're forgetful of their daily activities, such as forgetting to come to treatment, forgetting that they had practice, or forgetting that they had anything to do with athletics. So let's go to the next column about hyperactivity and impulsivity. They often fidget, tap their hands, tap their feet, and they squirm. They can't sit still. And you'll notice I have these pinkish cups on your tables, and they're filled with lovely little tiny things. And the reason is, research has actually shown that because patients with ADHD need sensory, and they often fidget because their body is saying, hey, you need to touch something, you need to fidget with something, that's what that is for. And I actually used that in a college class that I taught at BU, that we put this on the table every day. And I went to Dollar Tree and I bought little golf balls, koosh balls, little animals, little army soldiers. And that's for you literally to play with. So if you need to fidget, fidget. I don't care. If you need to flip a pen, I swear every day at work, I always have a pen on me because I have to fidget. But it makes me focus and makes me concentrate. So that's what that is there for. And please take them home if you have kids, whatever, make them play, have fun. They often leave their seat in situations when they can't be seated. They run and climb in situations when it is inappropriate. And this is very present in kids that are on the playground, middle school, high school, because usually patients with ADHD often mature later in life. So if they're wanting to like randomly climb and do extraneous activities in high school, that's a big red flag that, hey, they may actually have, whoopsies. All right, I'm gonna cancel this update. Sorry, folks. All right, we're good. That's all good. So yeah, climbing inappropriately, that's usually for kids at younger age, but it could happen in adults, you never know. Often on the go as if driven by a motor. You're probably wondering, like, where did they get all this energy from? Talks excessively, blurts out answers before a question is completed, has difficulty waiting their turn. They're sitting in their seat squirming and their hand is doing like this. Do we all remember those kids? We may have been those kids. Often interrupts and intrudes others. So these are, most of these, can you nod your head? Have you seen this or very familiar? None of these are very striking. But going on to the presentation, you can either have combined. You can have predominantly inattentive, or you can have predominantly hyper and impulsive. So you can have a combined presentation, or they can be separate. But the common theme here is that they have at least 6 of those symptoms we just talked about, and they have to be present for at least 6 months in order to be diagnosed with ADHD. So that's why it's so important that if you're an athletic trainer and you see a student or a patient that is struggling with this, make note of it and also alert your team physician, because your team physician is going to be the one making that diagnosis or referring to a psychologist to make that diagnosis, especially if the student has never been diagnosed with anything or had those resources before. So that's why it's very important if you have an incoming freshman that is bouncing off the walls and has those symptoms, it's start early documenting the time and when it happens and all of that. And the severity can be mild, moderate, and severe. The mild is like, okay, they have a few symptoms, but they can still function in life. They're a little annoying at times, but they get by. Moderate is like, okay, they have symptoms, and at times it gets a little rough to communicate with them or do something else. And then the severe is, it is debilitating. They can't communicate. They cannot participate well in groups. They can't do their school. They can't do anything. So we'll also talk a little bit more. How many of you have heard autism spectrum disorder? Yes, okay, very good. So it's a name of group of developmental disorders, and they have significant social problems, and they often have repetitive behaviors and limited activities. And you'll notice people with autism spectrum, they get focused on certain topics, and you cannot get their focus off of it, either be dinosaurs, cars, airplanes. They get very focused on activities, and you cannot draw their attention off of it. And it's because of this disorder. Usually you can recognize it in the first 2 years of life because their cognitive and the social deficits are so obvious. That's when you usually notice that if your child is severely delayed or can't speak or can't make eye contact, that usually pops up in a pediatrician's appointment. They ask about a lot of those developmental delays. Yet again, it can be mild, moderate, severe. And the biggest key is autism spectrum and ADHD, a lot of the symptoms overlap. So that's why it's very, very difficult to get an accurate diagnosis. And that's why it's so important to get a team physician, a psychologist, a psychiatrist involved, especially if there's medication involved. You need other people in your system to make sure that you can care for this patient in the best way. So here's a nice little picture of the autism spectrum disorder. And you'll notice there's all these little bubbles around it. And ADD, ADHD, those are bubbles. You have depression. Who knew depression was a part of autism spectrum? Anxiety disorder. Most of them, as you notice in this bottom corner right here, it says they're gifted. They are brilliant individuals. I'm pretty sure someone with autism spectrum or even different levels on the spectrum are probably more brilliant than all of us in this room. They are just highly gifted individuals. But because of their social deficits, they can't communicate, they can't talk, or we'll quickly just see a small video here in a second that will describe everything that's on this bubble, that even though we're only going to focus on the wedge of ADHD, we're only going to focus on that one bubble, it's very important to know that someone with ADHD can also have depression. They can also have anxiety. They can also have OCD. It's not just one bubble. There's a lot of overlap in symptoms. So if you have someone diagnosed with ADD, they're on the autism spectrum. And in most cases, honestly, a lot of us are probably somewhere on the spectrum, either with hyperactivity, can't focus, we fidget, whatever it is. But yet again, most of our symptoms probably aren't debilitating, but they're there. We notice them. But does this make sense, how the spectrum is a fluid thing? It's not a square box. There is no square box, period. And the same thing for ADHD, it's a circle, it's not a box. So I forgot to tell you I have a video, but I believe it should play. Actually, crap, the sound may not. Oh, I'm sorry. Is there any way do I have to get out of the presentation mode to show this? Okay. Okay. There's a little commercial, but it's not showing up here. So I was wondering if, okay, sorry. So sorry about that, guys. I did not think about this. Yeah, I can definitely send you the link. But long story short, there is a wonderful gentleman who just graduated from the University of South Carolina, my alma mater, and he not only is severely autistic, but his mother, it was an interview with NBC Nightly News that aired back, I think, in March or February. And his mother says that if you took him to the physician at early stages in life, he literally checked every single box on the autism spectrum. Like, he couldn't make eye contact with his mom. And even, his name is Jory Fleming. And Jory even said that early on in life, he could not communicate in words. He had to communicate with pictures. And so for the first several years of his life, he actually had to use pictures to communicate with his mom, to communicate with anybody. But the good thing is they got a lot of counseling. They had a lot of resources to help Jory overcome his symptoms and his disorders that he had. He is a Rhodes Scholar, and he just graduated with a 4.0, double major, and a minor, and he's now going to be at Oxford for the next several years as a Rhodes Scholar. So if that doesn't tell you everything about the autism spectrum, that the kid literally could not even communicate for the first several years of his life, and now he's going to go to Oxford. I think that's pretty cool. But we can definitely send out the link. It's still on NBC News, but that's his service dog, Daisy, and she even has her own Twitter. It's so adorable. But that's another thing. I mean, athletic trainers, should we be aware that service dogs might be a thing of the future for our patients? Literally. It's happening at University of North Carolina. It's happening everywhere. So that's another big thing of this presentation, is if someone has a service dog, it's for a reason. And that's one thing that we need to be in support of in the future if we're going to accommodate patients with these different types of disorders. So let's talk about some myths. Number one, patients with ADHD and autism spectrum, their behaviors are problematic, and they need to change in order to conform to our social norms. No, and as we discussed, they can't help it. This isn't a disease, it is a behavior problem. That's always a big one, especially if someone hasn't been diagnosed. They think it's a behavior problem, but we'll talk about that shortly. Medication will fix and cure them. Absolutely not. Medication is a piece of the puzzle, 100% of the puzzle, especially if you have someone with severe symptoms, either psychoses or some prescribed, and that's why it's important to get a psychiatrist or your team physician involved. But a psychologist cannot give medications, and neither can an athletic trainer. We can help disperse it, especially if someone's on Adderall or Ritalin or things like that. We can help with that, but we can't make the best practices or best distributing guidelines. We have to read the bottle. There's something wrong with them. Their behaviors are wrong. They're just acting weird. They will outgrow these. No, they do not. Just as if we were born with a physical deformity, we might get better over time. We might cope with our physical deformity, but we will never outgrow it. We have it for life. And depending on your environment, we'll talk about this, depending on everything around you, these symptoms and this disease can get better, but you will always have it. You can't outgrow it. So yet again, important to understand, it's not their fault. They cannot help it. They were born with this. And their behaviors that you're seeing, they are symptoms of a disease. And if we as athletic trainers are reprimanding our patients for not following the athletic training rules, or if they're not showing up on time, or they're being forgetful, we don't need to treat them as a behavior problem, because their behaviors are literally saying, hey, my disease is really bad today. I'm not focusing. Can you please help me? They're actually, their behaviors that they're displaying, or the symptoms that they are displaying, is saying, hey, I need help. Rather than shove me in the corner and discipline me, they're actually asking for help. And us shoving them away is not going to help them, and it's probably going to hurt them for the rest of their life, because it goes back to the bullying, and it goes back to harsh words that kids, they're sponges. And especially, we'll talk about this a little bit later, people with ADHD are ultra sponges. They react and feed off of exactly what we do and what we believe. And it's quite miraculous how we, in the smallest of ways, can affect big change, especially in patients that can't sometimes help themselves. So let's talk about an athletic training room. I don't know if your athletic training room is not like this, but they're usually busy. They're loud. And especially if you work in a high school, it is organized chaos between what, 3 and 3:30? You have about 300 people. You got to tape people. You got to get ice here. You got to get water jugs. You got to get ready for the game. But you are probably, as an athletic trainer, it's a perfectly timed sequence. Everyone has a job to do, but it's organized chaos in some ways. And we know that, but sometimes our patients don't know that. And unless we communicate that to them, it might be very hard for them to understand. We do have a lot of rules, but the reason we have these rules and procedures is for their safety. It's for our safety. And a lot of times there's one of us, and there may be 300 of them. We have to have some sort of rules in order to make sure we're even just getting our job done. So I get that. We all get that. But yet again, with some of these rules and constraints, we rely on our patients to be independent. Can you please go do this by your own? Can you do your own heel raises without me watching you? Can you please go and help make the water? You know, small tasks, but yet it alleviates some stress off of us. And I found, it's probably really bad pixelation up here, but I found some athletic training rules online. And it says, I really like this one. It says, athletes will be treated on a first come, first served basis. And we will gradually get to this point in our presentation where this rule itself is annihilating patients with this disorder. Our patients with ADHD, you'll come to know, they need one-on-one treatment, and saying, sorry, you came in late because you forgot your appointment time, go to the back of the line. That's not helping them cope with their disease, and that's not going to make them get better. And I know the reason we have this is because, okay, if you're getting taped, get in a line, and whoever's up there first, go. But when it comes to actually having one-on-one health care with patients with certain disorders that are on the autism spectrum, rules like this can be extremely detrimental. And I think my challenge to you is just, as we start this presentation, think about your own athletic training rules. A lot of them are about us and our patient safety, but are we really making it harder for patients with these disorders to flourish in this environment? But first, I need a volunteer.
Don't mess up.
Who spilled the water? All right, great job, great job. All right, Emily, now bring me back your complete Okay, so I saw you took a long time there, and you kind of skipped a few steps, and this, I mean, it looks pretty decent. You did a good job at rehab yesterday, but this isn't a perfect angle. Did you get distracted? Yeah. Why? What happened? Okay. I'll let you off. But doesn't that happen sometimes? That we ask a patient to go step by step through the rehab flow sheet, and then you'll notice, oh, they're over here talking to so-and-so, or, you know, maybe they didn't do 3 sets of 10, they maybe did 1 set of 10, or, you know, things happen. So thank you, Emily. Thank you for the lovely demonstration. Thank you to all the audience. All right, great job, great efforts. But does that example make sense? That literally everything is a distraction, including us. So where does this leave us? We have ADHD, we have our square peg. Athletic training is definitely a round hole. And guess what? Apollo 13, they were able to fix their problem in space. So if Apollo 13 and NASA was able to make 2 air filters that were literally square and round in the middle of space from using junk, from using this, I think athletic training, I have really good faith that we can fix our problem too. And I think, honestly, we have a lot more resources than Apollo 13 had in space, and we have some great people. We have a lot of young, great professionals in our profession. So we're going to keep moving, but you may have some questions. Knowing all of this, are we setting our patients up to fail every day? Can patients with ADHD be successful in an environment that's not made for them? Are ATs trained and equipped to care for these patients? So coming out of our BOC accredited programs, straight off, if one of our first patients as a brand new AT has a disease such as ADHD or one of the other disorders on the spectrum, can we care for them? Do we know what to do? Does an AT have an obligation to accommodate these patients? So by the standards of the BOC and maybe even our state practice acts, are we obligated to accommodate them? It's a good, fair question. What are the burdens and additional work and the resources that the athletic trainer will have to exert in order to accommodate these patients? Because I know that was one of the things when I was coming up with this project. There's only one of me. I only have a small amount of time, and there's no way I can have a one-on-one treatment time with about 50 individuals every day. It's just not going to happen. And yet again, if you're an athletic trainer at a high school and you literally have a broom closet as a facility, what are you going to do? And you have no budget. These are all valid concerns, and we're definitely going to talk about them. And I unfortunately don't have perfect answers for everybody. And that's why we're going to talk about a support system and who you can go to, or maybe some little tricks to make sure that your patients are getting the help that they need. Or you can just be screaming internally, don't know what to say, have no questions. That's okay too. If you don't have any or overwhelmed, that's okay. Take a deep breath. I'm going to try to make this as simple and easy as possible. So what does the evidence say? That's a good question. So as I, in graduate school, had a patient that had basically a lot of the symptoms of ADHD, I myself was having a very difficult time not only talking to this patient, but just relating on a one-on-one basis, getting like daily feedback about how do you feel today? That was honestly like the most painful discussion I think I had every day. And it was because of how I was asking it, not how he was responding. And that's what took me a long time, is the more I changed my behavior, I got the behavior that I was looking for. And so that's the whole reason I pursued this project, and that's the whole reason we're talking about it today. Last year, I published a systematic review with a buddy of mine that is a sports psychologist at BU. We came up with some evidence-based considerations for athletic trainers, specifically that talks about ADHD. You know, we have a lot of evidence-based protocols for how to treat an ankle sprain and how to do an ACL and all of this other stuff. But when it comes to mental health, we have nothing. And because this is such a big, hot topic right now that we really need to talk about, I was like, you know what, this is a first step in at least a direction. So we'll see. But the purpose of this was to provide you, athletic trainers, and other healthcare professionals with evidence-based considerations and just something tangible that you can use caring for your patients. So at least you have some place to start. It's not an end-all, be-all. This isn't, if you have someone with ADHD, this is going to be the perfect fix. It is absolutely not. It is to start the conversation and to give you some tools to work with. I don't want to bore you with research stuff, but this is how we got the data. So we looked at 3 different databases, and we didn't have any time restrictions because we wanted to see what evidence is out there, regardless of date. The search terms is we use ADHD and one of those 5 terms, so ADHD in athletic training, ADHD in athletics. We wanted to see what research was out there for all of the different topics that revolve around our profession, and how they intertwine, and if there was anything, because we wanted to know what are other professions doing that we aren't. So we typed all that in. We read all the abstracts, and that the abstracts did not relate to physically active people or athletic populations in general. We tossed it out. If it did not revolve around physical rehabilitation, and I say physical rehab because when you get with diseases and disorders such as ADHD and autism spectrum, rehab could be psychological. It could be that you're in a psychiatric unit someplace. So we narrowed it down to physical rehab because we're actually talking about the profession of athletic training and treating people with physical illnesses and injuries. And we only looked at non-pharmacologic interventions. So anything that dealt with medication, we threw it out because for athletic trainers, that's not a part. If a patient is prescribed meds, awesome, we'll follow the doctor's directions, but we're not going to be making the choice and decision who gets Ritalin and who doesn't. That's not our purview. And the same thing with some psychological interventions, because we are not licensed counselors. I felt like that was also out of our scope of practice. So I tried to make sure that these guidelines were not challenging our scope of practice in any means. And if they met all of those criteria, we moved on and reviewed the full article. And so anything that was not related to physical rehab, AT, or anything within sport and exercise psychology, we threw it out. And some of those examples are ADHD in the classroom. I know we've talked about classroom accommodations in educational settings. Non-athletic patients, you'd be surprised about how many articles there are about the adult population, that adults that either are dealing with their ADHD or adults that have never been diagnosed. But yet again, we tried to tailor this more towards a young, either high school or college population. So if it was dealing with adults, we tossed it out. Same thing, pharmacologic treatment, drugs, we tossed it out. ADHD and stimulant misuse. There's a lot of literature, and you'll probably see this a lot in your colleges and high schools. People with ADHD do have addictive tendencies. And there are a lot of new reports out there about ADHD and, heroin and opioids, but we didn't want to really get into the stimulant misuse because that is a whole nother thing to deal with. But there is a lot of research out there. So if you are an athletic trainer and you have someone with ADHD that does have other behavioral health problems, you definitely need to talk to your team physicians because that is a burden within itself. But just decided that we didn't include this in that. So yet again, another conversation for another day. Same thing, we disclosed, there was a lot of clinical psychology interventions, prisoner studies. You would be surprised, there are a lot of prisoners. And yet again, it goes back to prisoners that probably had bad behavior or egregious behaviors, but were their behaviors because they actually have an undiagnosed disorder. So that was the whole, there are a lot of prisoner studies where they're actually shocking to find there are a lot of prisoners with autism spectrum disorders. And yet again, family counseling and parenting. Parents are a big part of the picture, but for us, that we wanted to keep it focused on just athletic training, clinical practice. The parents are definitely a great resource, but this is mainly about us. So if an article met all of that conclusion, or all of that included inclusion criteria, we looked at it, we reviewed it, and then we tried to cluster them into common themes. And that's the 5 common themes is what we're going to talk about right now. So how many articles did we read? A lot. Not gonna lie, it was about 6 months out of my life. It was over 1,200 of them that we read, and only 86 were included. So that's how much the evidence that we got, we're like, this is robust. Even though if you're a statistician or a researcher out there, you're probably thinking, wow, your inclusion percentage is really low. Yeah, I know that. But if you read all the other articles, you're like, yeah, that probably doesn't fit athletic training either. So we wanted to be very, very, very sure that our evidence was 100% for us. So the 5 themes are listed here: goal setting and coaching, reinforcements and outcomes, routines and treatment timing, simplified feedback and instructions, and environmental control. And we're going to go through each one of these. And if you hang with me for a few more slides, I promise you get a break. So let's talk first about goal setting. It is extremely important. You probably do this. How many of you are preceptors for undergrad programs? Yeah, a few of you? Okay. Or if you came through any undergraduate program, the first thing you did at every semester was what? Set goals, set all these goals about what you wanted to do. At least for all the newer programs, it's all about goal setting. However, the athletic training goal setting is going to be very different than goal setting for someone with ADHD. So the patient that has ADHD, they need to tell you what they want to accomplish. And yet again, because a lot of them cannot communicate, that's why it's really important that you have a one-on-one relationship with your patient. So if they need to draw a picture about what they want to be able to do, let them draw a picture. If they communicate another way and can't verbalize it, they need to drive that conversation about what they want to do. And who knows, it may not be return to sport. Maybe it might be, I just want to pass my term paper that's due tomorrow. It may be something completely different that's not related to sport. And yet again, athletic trainers facilitate that conversation. Goal contagion. This basically means sponges. If you know anything, goal contagion means sponges. The patient will pursue and adopt a goal that is implied by another person's behavior. And guess what? That other person is us. So yet again, if our patient says, you know, we'll use the example that's in the next slide. I want to be able to run on the treadmill within 3 weeks with no pain. Awesome. But for me, I want you to play in the game on Saturday. That's what I really want for you. But guess what? That's not their goal. So if we embody their goal and say, okay, you're going to take your time getting back. Okay, cool. I'm good with that too. I'm not going to push you. We want to go at the pace that they want to go at. But yet if you, every day, the rehab that you do, your interactions with them embodies what they want to do, they're going to feed off your energy. If one day you're having a Debbie Downer day and it's really hard, they're probably going to feel the same way. You know, that slogan, attitudes are contagious and is yours worth catching? That literally is goal contagion within one little slogan. So it's really important that we really are the trendsetters and the motivating factors for our patients. For goal setting and goal contagion, it can increase their compliance with finishing and coming to rehab, but also it increases their attendance. I know sometimes for collegiate athletes, they may have to come to treatment because that might be mandated, but for high school patients or someone else that's not necessarily at the collegiate level, it might just be, okay, they just didn't show up today, whatever. But if you use these types of goal settings, then we'll talk a little bit later about some reinforcements. This provides the patient to be in charge of their destiny. This is their goal. This is their treatment plan. We're there to support them. But they need to drive their own engine, and some of the things that we need to do in our clinical practice will help them drive their own engine. And a big piece of this is it gives them hope, and it gives them self-esteem and confidence. And why is this big? As we talked about the autism spectrum, did you see depression was on there? OCD was on there, anxiety was on there. So a lot of these patients are not just dealing with ADHD. They have a lot of other pieces in the puzzle going on at the same time. So if we use goal contagion and we have a supporting environment for them, it's going to be a little bit easier for them to build up their self-esteem and build up their confidence. All right, SMART goals. We've all talked about this probably in some way, shape, or form in athletic training, but it is a specific, measurable, attainable, realistic, and time-sensitive. But a big piece here is the first two bullets, is that the goals need to be safe and tailored to their physical needs and motor function. And the reason is I'm sorry we didn't get to see that video with Jory Fleming. Jory actually has 2 braces on the backside of his Achilles, is because he actually has a physical deficit that his motor function doesn't allow him to get up on his calf and on his toes, so he actually has to have braces. And you'll notice sometimes a lot of ADHD patients are clumsy, they fall all over, they don't have a lot of motor control, and that's because of this disorder. They don't. That's actually another symptom, a physical symptom of ADHD. So the goals that you set for their treatment must be set within what they can currently do. So if they're coordinated enough, maybe if they're really, really bad on balance, don't make them do an entire rehab that's just on balance. Maybe have some exercises to make their balance get better, but don't make the balance the belligerent point that they have to get better, because sometimes it may take months or years, and it may be a part of their disorder that their balance is as good as it's going to get. and we have to be okay with that. But it may make them get injured more. Utilizing teachbacks, we're going to talk about this a little bit later, a little bit more, but having the patient demonstrate back an exercise that you just taught to them can make sure that they're doing it correctly and make sure that they don't get injured. And it also makes sure that it's not going in one ear and out the other. Yet again, that's another symptom of ADHD. And here's a small table that's actually in the article that I wrote. If you would like the article that I wrote, it's for free on the NATA website. And due to copyright, I was unfortunately not able to print it off tonight. But if you want a copy, come talk to me afterwards or email me, and I can figure out a way to get you a copy. But this just gives some examples about what a SMART goal is. And the big part of this SMART goal initiative is the GEM, the GEM. You may have never heard of SMART GEM, and it's goal evaluation method. So yet again, evaluating the goal of your patients. That's the whole point. It's not just setting a goal and I want to attain this. It's how you evaluate how you get there. Because patients with ADHD have to have step-by-step procedural instructions on how they're going to do it, or otherwise they're just going to score all over the place and never finish anything. All right, reinforcements and outcomes. Positive reinforcements is the key here. Don't be negative, don't chastise, don't criticize, because yet again, what we talked about with goal contagion, they're a sponge. If you are that way to them, they're going to be that way back, or because of maybe some of their self-confidence issues, they're going to shy away and be terrified of you. But having some type of positive reinforcement for either attendance, completing a goal, whatever it may be. So some examples of that are having, how many of us in kindergarten probably had an attendance sheet where we put a gold star every day for how many times we came? Do the same thing for your athletic training facility. I promise you, it may seem small, and we don't do this for 20-year-old kids, but it is awesome. It's the best way to reinforce attendance, so they can see, guess what, I missed on Tuesday. I really don't like having this blank spot on my attendance sheet, but it's a positive reinforcement that every day that they come in and they can go put that and say, guess what, I came in today. That's one win for me that no one can take away. I did that for myself. It's a great reinforcement. Visual outcomes measures. I know sometimes in our clinics, we do a lot of outcomes measures where we may ask them, what is your pain today, or whatever, and we mark it on our own, I guess, what you call it, I don't know, rehab sheets or whatever we do, our own outcomes. But having something such as, if you want a patient to get range of motion back, maybe having a chart that shows range of motion. Like today, if you want them to get to -2 degrees of extension on their knee, and they started out at +10, and then the next week they're at +5. The next week they might be close to 0. So they can have a visual signal of how close they are to where they need to be. Because just saying the numbers, if they don't communicate in numbers, that's just going to be gibberish, and it's going to whoop. It's going to go one ear and out the other. But if they have a visual sign, either a chart or whatever it may be, of what their goal is, they can probably relate to it better. Yet again, progress reports are really good for motivation. And especially for home programs. So if you're giving them stretching to do at home or something like that, if they can actually come in and prove to you and say, my mom signed off and I did all of my core exercises and stretching last night, so can I get an extra gold star? That's another positive reinforcement. And yet again, it brings in the parents, it brings in the roommates, and the roommates, it brings in what you're looking for, because they're going to need a lot of help. An important equation. Positive reinforcing behaviors, tangible feedback. Tangible is the key. It means that we can actually help improve their quality of life. Why is this important? Quality of life is a huge factor for financial reimbursement for healthcare. If we can show and quantify and prove that we are helping our patients get better on a qualitative, like mental way, but also in a physical way, and we can show them their range of motion got better and here's their numbers. If we can show from both sides of the coin that we're helping them get better, this is an easy way for us to justify to get paid. So that's another conversation, but just to, if you're also trying to justify another FTE, or if you're trying to justify more funding for your athletic training program, having this and saying, guess what, for your patients that have these mental disorders, this is how much we're saving you, or this is an additional service that we're providing. that money and those families will sing your blessings. So it's another way that we can support our profession. All right, I promise we're getting really close to the break. This is the last slide before break. Routines and treatment timing. Patients with ADHD have to have consistency. They need a schedule, and this helps them stay on task and remember things. Just like many of us, when we first wake up, we have a routine. For me, it's coffee, bathroom, shower, and then go back for breakfast. And we probably all have similar routines, but it's to make sure that we hit all the check boxes of what we need to do in order to get our day off to a good start. For people with ADHD, it is no different. So establishing a routine treatment time every day or every other day, whatever it may be, for these patients is key. And that's for two reasons. Number one, if Johnny has an ankle sprain and Johnny needs to come in 3 times a week, maybe saying Johnny can come in 3 o'clock here, maybe 1 o'clock here, and maybe 7 a.m. on this day. Was Johnny going to remember that? Probably not, unless he wrote it down or had some other type of reminder. But if you said every day at 11:30, so Johnny, before you go to lunch, you come see me every day. You cannot eat lunch before you see me. So it not only sets up a time, but for you as the athletic trainer, when you set up that appointment to meet with Johnny, you yourself can make sure I don't schedule anyone else around Johnny. I can see people before, I can see them after, I can see them all the other times. This is Johnny's time. So it kind of goes both ways. So if you're wondering, how am I going to set up that one-on-one treatment time? That's an option. Put them first, what time works for you, and when we can make this work every day. And if you don't come in, we know that you're not going to get your gold star for today. Or if he doesn't come in, let's find a time that works better. But yet again, having these moments of flexibility too. Flexibility is huge because some days, especially when I worked at BU, the train broke down, the bus didn't show up. So you're going to have things that happen, but allowing the patient to have a realm of flexibility so that they can make it up or be in charge of saying, okay, Johnny, you didn't come in at 11:30. You tell me when you're going to make this up. Have them put it back on them so they can take control. And having between session assignments, like I said, with giving the example of having Johnny stretch at home and have mom and dad sign off on it, that can help them increase not only their self-worth, but it makes them work harder towards the goals. And also it establishes some treatment gains as well. Make sense? Nodding heads, I like that.
I guess I would ask, you're always talking about ADHD, and do you differentiate that from ADD?
Great question. So for the viewers online, we just had a question about, right now this presentation is about ADHD, and I guess, is there anything different, or how is that different from ADD? The only thing is, with ADD, it is only the inattentive part. They don't necessarily have the hyperactivity and impulsive. And usually from my experiences with those that only have ADD, they're a little bit more mellow. They're not the ones that are bouncing off the walls, but they primarily just have a lot of academic issues. They might need an IEP or an individualized education plan, but they don't need the cognitive behavioral parts. Usually on that side, they're able to do pretty okay. But the only difference is the hyperactivity, impulsivity part. Good question. But yet again, it's on the spectrum too.
Yeah.
So. Yes. So the question was, could it be either ADD or ADHD or one or the other? But yes, usually from my experiences, it's either one or the other. So ADD, you're not going to have that whole list on the right-hand side of the hyperactivity and impulsive. It's just going to be, they only have the inattentive symptoms, and they have to have 6 of them, and they have to have it for 6 months or longer. So that's, yet again, this is not anything on the autism spectrum, specifically ADD and ADHD. It's a half a year to get a confirmed diagnosis. And then even after that, if your physician or psychiatrist says that they need to go on medication, that whole finding out how much, what meds, that's a whole process within itself. That does take some time. Any questions online? No? Any others here? Those are good questions. Yeah.
What about with NCAA rules on my ADHD medication, and even like MLS and like other certain like major sports, they don't allow that medication, so what do you do?
That is a very good question. So for those online, we had a question about the NCAA and other major sports leagues. If you have a patient with ADHD and they have to be on certain stimulant medications such as Ritalin and Adderall, what do we do? That is a very good question. And I know there's one segment on here that I do talk about the NCAA. From my experiences, as long as they have a prescription that's written for the patient for that medication and it is documented and the team physician knows about it and it's in their patient chart at their institution, I believe it is still okay for them to participate because they need that medication to function in life. But if they are taking a medication and they test positive for it and they do not have a prescription, that's a whole nother ball of wax, and that's usually disciplinary action, the whole 9 yards.
The military have a situation where it's not allowed. It's going in boot camp. I just had to come back. He graduated. But unbelievable.
Yeah.
Okay. Sitting in the training room just bouncing.
Yeah. So we just had a comment about the military, that the military also doesn't allow those prescription stimulant medications, and it's hard for those. You have one question in the back.
Just a comment on yours. I was in Major League Baseball for 10 years, and the kind of stuff, the hoops that make you go through is such a pain in the ass.
Yeah.
You have to see a psychiatrist probably 3 times a year. You get tested probably once a month to make sure you're still on it. If there's a lapse in medication, you don't get the medication 1 month, you're automatically off it. So they have like I don't know what the exact word, but they make you go on it, get documentation even during the off season. So and then they test you during the off season twice. So it's huge.
So we had a comment about someone that worked in Major League Baseball for several years, and there's a lot of documentation, there's a lot of processes, so they could still take the medication for ADD, ADHD, but there's a very rigorous testing and documentation process. And correct me if I'm wrong, but from my personal own family experiences, I know if someone is prescribed this stimulant medication such as Ritalin, Adderall, they are only given 31 pills, how many ever days there are in a month. That is it. So any more, any less. I know a lot of places are doing pill counts.
Well, it's a hard copy. You have to get a hard copy from your primary care or your psychologist, whoever is prescribing that medication. And they check what's called MassPat. So if you go, because I work in a primary care office, I'm also a nurse.
There you go.
So I have to check what's called MassPat, and I can see where you filled it, how much you filled it, if you bought it from another prescriber. So it's pretty serious stuff.
Yeah, so we just had a comment from someone that works in primary care, and here in Massachusetts, there is actually a tracking system that can see where and when your prescription was prescribed, and if you filled it. There's a way to track all of that. Are we still good online? Okay, let's move on. We're about halfway through these recommendations. So next, we're going to talk about feedback and instructions. Patients with ADHD cannot process multiple things at one time. So just the case that we had of Emily in this lovely demonstration, when you're throwing all these stimuli at someone at one time, it can be very difficult to focus. And yet again, you're trying to make them do 6 different things at one time, and they have all this going around. It's very, very difficult. So what do? Provide single-tiered tasks and single-tiered streamlined feedback. So what does that mean? Literally for a rehab sheet, give them 1 exercise at a time. Is that time consuming? Yes, but can they mess up 1 thing at a time? It's hard. You just give them literally just 1 thing, and maybe they can, I might be wrong, but at least it helps alleviate some of the other variables. If they're just focusing on 1 thing, it might make it a little easier. And streamlined feedback, what does that mean? Make sure it's very specific, it's very direct, concise, and it's not long-winded. Don't tell them a novel of instructions when 2 words will do. And to go along with that, some people with ADD and other disorders on the spectrum, they cannot understand metaphorical humor or any other types of jokes. So sometimes they may take your instructions very literally. So that's why sometimes don't use metaphors or jokes to joke around with them. If you want them to do 5-minute warm-up on a bike, Don't say go over there and warm up on the bike and until you start sweating. Like they don't understand that, or go warm up the regular way that you do for your sport. They literally may start running around the room warming up as they're warming up for their sport. I've seen it happen. So they're very literal. So be very, very cautious in knowing that if you want them to do one very specific task, be extremely literal so they can't misinterpret it. Examples. So yet again, we keep going back to this rehab flow sheet because there's actually a lot of research out there about, especially with teachers in school, giving someone instructions, especially for standardized tests. It's just overwhelming with someone with ADHD. So write all of the exercises either on a blank note card or a tongue depressor or something that you have around your athletic training facility. Write one exercise and how many repetitions, and what happens is you will walk this patient through all the exercises that you want them to do, and we'll give some other instructions later on about naming them and coming up with a more personalized exercise plan. But by giving them one tongue depressor at a time and say, Johnny, go do exercise number 1, and he sees his popsicle stick, he carries it with him, he goes to the area that he's doing rehab or wherever it is, and he says, okay, I need to do bicep curls, and I need to do 30 of them, and I need to do 2-pound weight. So Johnny's going to take that popsicle stick, he's going to do it, and when he completes it, he'll bring it back to the athletic trainer, and at that time, you can have a conversation. How's your pain? How did it feel? Do you feel better today than yesterday? Do we need to adjust your weight? That's when you have that one-on-one feedback, and then you can make adjustments and say, okay, great. Here's your next exercise. So yet again, they don't have to carry a flow sheet. They don't have to carry a lot of things because think about, yet again, a symptom. They very easily lose things. So if we give them a lot of stuff to go do their rehab, more than likely they're not going to come back with everything, or they're going to lose their sheet or it falls someplace. So this tactic of having simplified instructions and writing it on something makes it a little bit easier. And I actually got this example from graduate school at BU. This is literally how we clean up the athletic training facility every day. It was written on popsicle sticks. We laid them all out, and we did everything on those popsicle sticks until everyone was put back in the Gatorade cup, and then everyone went home. I was like, well, if it works for athletic trainers and we can clean a room, it must work okay. But for patients, it actually works just as well. Environmental control. This is the most important, but honestly the most difficult thing of this whole entire protocol. It seems easy to have an environment free of distractions, and also it's a huge pointer that especially if someone is hyperactive and impulsive, they can be a distraction to others. And I think sometimes we often forget that, but it's very easy. It's a two-way street. So in having environmental control, how, where? My facility is literally a broom closet. How am I supposed to do this? There are a lot of questions, and here's a few points that we can hit on today. Partition off a section of your athletic training facility that is just for them. That's Johnny's space. And also have a conversation with your other patients or athletes. That's Johnny's space. When he's here, leave him alone. Don't touch him. If you also needed accommodations, or if you had a special condition that you needed for your health care, treat them the same way. And I guarantee you that they will be respectful of that. And that can also be if you have like one of those little curtains, like for a doctor's visit, to create a little private space, that could also work. Or if you have a private treatment room or a private room for your physicians or whatever it may be, those are just examples of spaces that, yet again, at 11:30 every day, that's where Johnny's going to go. And that he knows that's his spot, that's where he's going to be, and that's where you're going to have your treatment session. So yet again, setting up a routine. Can't mess it up. Every day, this is where I'm going to go. Arrange one-on-one appointment times. We just kind of covered that. But at that same time, if you can arrange a one-on-one time with your patients, make sure the room is closed, that Johnny's the only person in there. You shut the door if you can, or just minimize the amount of other people that are in there. That will definitely help minimize the other distractions that are around. If you don't have space, I know this is a huge problem, you can always go outdoors. And there actually is research about this, that patients with ADHD do function very well in outdoor green spaces. And here's some pictures. So having a nice little space, especially if you're having kids that want to study or work on special projects, or if it's a nice day. I know in Massachusetts, I mean, it's cold 9 months out of the year here. And so on the first nice day, who doesn't want to go outside? I know I do. But yet again, having green spaces and being in the sunshine, getting some vitamin D, getting some fresh air will help them calm down, and it will also eliminate those extraneous stimuli that can make their symptoms worse. And this is actually a picture on the bottom left of a PT clinic that modified an area that specialed off for just specific patients to create a little bit more privacy. I know that's an extreme situation. That really looks like a really nice rugged clinic right there. I know my athletic training facilities I've ever worked at are not that nice. But those are just some examples. Yet again, I know all of us have our different constraints. There's money involved, there's time involved, there's space, I get it, but these are just recommendations of what the evidence has said that works best. All right, here's where we kind of turn the conversation on ourselves. The returning the rehab flow sheet when completed tactic does not work. If you remember anything from this presentation, just know that if you have a patient with any of the disorders on the spectrum, that mentality doesn't work. And unfortunately, for our profession, that's been our motto for years, if not for the entire length of our profession. And just remind yourself that this is a disorder of the brain, that these patients think differently, they're hardwired differently, and they can't help it. So it's not our fault that they can't remember to do things in a certain order, or they can't behave the way that we want them to, but their disease prohibits them from doing it. They can't process numerous tasks, and it's not a personal weakness. That's also another thing that kind of goes back to the myth of this is a behavior problem. Just because they cannot function in a busy environment doesn't mean that they're a bad person. It doesn't mean that they're not capable of being a great student. Look at the case of Jory. He's a Rhodes Scholar and has like 4 degrees, and he's like 21 years old, and he graduated with a 4.0. So he's just the case in point that these disorders come with a lot of symptoms, but it doesn't mean that they're not going to succeed. And the reason they do succeed is because the environment that we surround them with and the stimuli that we provide them so that they can be successful. And I think I belligered this third point a lot. You know, this is a symptom and disease problem. It's not a personal problem. It's not a behavior problem. And if you leave with anything, just know that. So this cultural alteration, have they been doing it elsewhere in the United States? And the answer is yes. Especially in emergency rooms, I found several articles about how they're modifying emergency rooms across the United States that are just for patients with autism and autism spectrum disorders. So they have a private treatment room. So if a parent comes in with a sick child with autism, they actually have a room that is just designated, that's completely closed off for that autistic patient. And what happened when ER started to do that, they had an influx of autistic patients because word got out that, you know, this ER accommodates my child. And I want to tell all the other mothers that have sick children, either with the flu or whatever it may be, that you don't have to have a painful visit to the doctor, because you can go to this place and have the best care possible because they're tailoring it to the disease your kid has. And I think, honestly, every healthcare facility should do that. And that's kind of the third point. If the ER can do it, why can't we? The ER sees 400 patients a day. Yes, we might see 400 patients, but the ER is a very dynamic environment. And, I think this sparks some conversations about what we do every day and why. Is it just because we've done this forever? And is there a way that we can change it or do small changes? But yeah, we got a question? Go ahead.
Yeah, sort of a comment. Some people might be familiar with the term universal design.
Mm-hmm.
And that kind of speaks to this, where the example of, having an entrance with a ramp and stairs automatically built in, or just ramps altogether without stairs.
Mm-hmm.
And, as we build new buildings, that's kind of what comes to mind. I have a background working with athletes with disabilities, mental and physical impairments, and in working with them, it kind of came to mind, like, you can design things so that it's universal design. And so I was thinking about that when you were talking about some of those things and how a lot of us have the same symptoms already, that if you can sort of keep, change your environment a little bit, with this in mind, it still would help a lot of other people too, whether they're on the spectrum or not, they have ADHD. You know, I take an exercise class and there's another one going on over there. It gets distracting for me at times, and I usually don't struggle with any of that, but if they're having a lot of fun over there, it's going to distract me.
Yeah.
So, you know.
Especially if they're yelling and screaming and have better music, you know.
Yeah. And I now work in a hospital setting, so we see the same thing too, where our hospital setting had a lot of male patients, and we want to attract more female patients. So there's things we're doing to make them more comfortable for some of those situations. But it's really just keeping in mind that having that, if you do that in general, if you kind of take note of some of these things and just try to be conscious about them and doing them in general, and also like the way you approach your patients, like you're saying, ask them what their goals are. And I was kind of thinking, I think that's a great question to ask your athletes in general across the board. Or saying, you know, it's kind of chaotic in here. Are you going to be okay? Do you want to try and take your stuff over there? And just offering that to anybody in general, so that anybody will be successful and it'll help them be successful.
Yeah, you're not forcing them to stay in a place that they're not comfortable.
But just like thinking of the options and thinking of things that help people be successful in general, and just offering that, and then noticing when some people don't realize they may or may not need that, and then encouraging them, or just saying, oh, there's so much going on over here, let's go over here and work over here. Sometimes you have to help them remove themselves from that and take them over there. And that's the other point I want to make too, is like have a sense of humor and have a sense of grace, and helping them sort of realize some of their impairments, but do it kindly mindfully in front of other people, and just do that.
Yep.
Is really
Goes back to gold contagion, being a sponge.
Yeah.
You're reflecting the behaviors and the manners that you want back. So I guess with people online, we just had a great comment from someone here in the audience about, I guess, having universal facilities and universal healthcare, especially with American Disabilities Act, of having like ramps and stairs, and then just maybe molding our environment to kind of capture all the things that we're talking about today. And especially if our patients in our athletic training facilities are saying to us that I just can't focus in here, or this might not be productive, that we're open to that, and we're encouraging them to seek out places that are more tailored to their needs. So roughly, it was a great comment. Awesome. We have one from online.
Yeah, they asked, how do you manage the care of the ADHD athlete between the athletic trainer and the coaches, and is there a plan set for that?
Great question online. I'm actually going to take that question when we talk about the NCAA things at the very end. So you're jumping ahead of me, but great job. You get a gold star. All right. This is the meat and potatoes of this entire presentation. So Manos has this awesome paper on ADHD that basically sums up everything that we're talking about. The two things that we're going to talk about in this slide and next one are the defect model and the difference models, and how they're different but also the same in the same time. So the defect model is finding that there's a disease, and we can point out this is the problem. The problem is right here. It's identifying the issue within the individual. And I have two short examples here, but I'll just go over the first one. So the athletic trainer and healthcare provider reprimands the patient for a lack of discipline and focus while they're doing their rehab. So little Johnny didn't focus, so I need to encourage them by saying, you need to focus harder. Why aren't you doing your stuff? Why aren't you doing what you're supposed to be doing? Why are you wandering over here? So that's the defect models, that you're noticing there's a behavior and that it's wrong, and we're calling them out for it. The difference model is that the patient becomes an agent of change to make the environment work for them and to tackle their symptoms. And using the same example, but using the difference models, the athletic trainer notices that the patient can't focus. So the athletic trainer asks the patient, what do you need right now so that you can focus? I'm noticing you're not focusing, so we're noticing the symptom, but we're asking them, what do you need? So it directly goes back to your situation that we just talked about. So instead of defecting them, that they have a fault or a wrong in them, we're saying, okay, we know that there's something not there, so we're indifferent about it, but yet how can we meet halfway? What can we do to work together, and what can we do to make sure that your symptom doesn't debilitate you, that we can make sure your symptom doesn't get worse. How, you know, what do we need to do to help you cope better? So yet again, the defect is a function that cannot change its cause. No matter how hard the athlete wants to try and wants to change, they can't. They were born with it. They cannot help it. So yet again, I'm belligerent this point that this disease, no matter how much we think this is a behavior problem, it's not. It's a disease. It's a symptom. It's a disorder. And yet the difference model is showing that how athletic trainers can be the facilitators and can be that engine to guide the ADHD patient to take control, to manage, and engage with their environment that's not made for them to minimize their symptoms. So we kind of already had a dialogue earlier about, you know, if a patient knows that the athletic training room is crazy and they're already stressed out about doing the rehab when there's 50 other people in there, they can say, I need to go outside. And for us to be okay with that and facilitate that, that's what they want. They're telling you what they need. We need to be on board with that. And I know there's probably some extraneous things. If you have 50 other people in the room, can you tell that patient, can you wait 5 minutes? Sit right here, Johnny. Let me take care of them. So in 5 minutes, I can take care of you, or let me get your rehab plan, or let me get your popsicle sticks with your exercises on it so he can go do what he needs to. Don't shove them at the line. And yet again, the example from the athletic training room rules, first come, first served. That's a prime example of first come, first served. And Johnny was the last one, but yet we didn't shove him to the side and say, get in line. We just said, pause, let's come back. So yet again, we're trying to mold that environment so that we're not pushing them away, we're not making their symptoms better, and we're not ignoring them. Because sometimes these symptoms are so blatant, you're like, wow, Johnny, you're being really annoying today. But sometimes they're crying out for help because no one else has listened to them all day. Or who knows, their home life may be bad, or there may be another issue going on, because yet again, let's bring it back to the spectrum. They may be having a manic depressive disorder situation. They may be having an anxiety attack. Who knows what's going on? So a lot of times when their symptoms and behaviors are so egregious, we need to hit time out. Johnny, are you okay? Okay, you didn't take your medicine today? All right, first thing, go to the school nurse, take your medicine. You know, sometimes it might take that, just hitting a pause and saying, where are you at? Or do you need to talk? Those are some easy things that we can do to become a difference and not treat them as a defect. We okay with that? Any questions? That make sense? You may have heard that for the first time, and I remember when I read this, I was like, oh my goodness, my mind is just like, this is the meat and potatoes of basically a lot of things that we do in our lives. Instead of having someone else figure out their own issues, we didn't know that, hey, we can actually be a part of the solution and not a part of the problem. And I think for athletic trainers, it's really important for us to be aware of it. So some sports psychology things. I remember at the beginning, we're going to talk about 2, and actually kind of 3-ish, 2.5, if you rather. Self-determination theory. Ooh. People need to satisfy 3 needs in their life, regardless of who they are in this world. They need to be autonomous, competent, and they have to have relatedness. So how do we relate to each other? Those are the 3 basic needs. And in self-determination theory, there's 3 types of motivation. Most of these you probably already know. Intrinsically motivated, so they come motivated from inside. Extrinsically motivated, so someone from the outside, either be a coach, parent, athletic trainer, whatever. And then amotivated is a person that's just flat out, doesn't care, not motivated, no goals, is just a blob in the world. They have no motivation in life. So why do we need to know this? For patients with ADHD, yet again, here's another spectrum of motivation. And we know that ADHD is also a part of a spectrum. But someone that's not motivated, is amotivated, they're not going to be autonomous at all. And to kind of go back to the very beginning, how we were talking about autonomy, we want our ADHD patients to be autonomous, but we know that their disease does not let them do that. So if someone doesn't have motivation, they're not going to have any autonomy whatsoever. But extrinsic motivation, you see that's kind of the larger piece of that spectrum. So if we have a coach, an athletic trainer, a parent, a peer, whoever it is kind of pushing them, they're going to be more motivated to say, hey, I'm going to set a goal and I want to achieve it. Or they're going to set higher goals. They're going to set more goals, whatever it is. So they're going to be more internally, the higher you go on this spectrum of autonomy, the more goals and the more driven they are. They eventually get to intrinsic, and intrinsic is the prime. This is where we want to be with every single one of our patients. We want them to be autonomous, in control. We want them to be happy. We want them to enjoy what they're doing. So yet again, enjoy, interest, pleasure. That's the prime situation. But unfortunately, depending on their symptoms, some patients may never get even halfway. They may have to constantly have an extrinsic motivator, such as athletic trainers or mom or dad or whoever it is, to push them to be autonomous. So it's important to know that sometimes our patients may need a little motivation, or they may need a lot. Or some days they're just going to come in and say, I'm not motivated at all. I don't want to be here. And it's because maybe some other part of their life isn't good. Or maybe today they're really struggling with depression or whatever it may be. So it's really important to know motivating factors and why the behaviors of how someone may change. That's the reason why. Does that make sense? I know it's a kind of a confusing slide if you're not interpreting it in just certain ways. Self-directed learning. We kind of already hit on this with the teach backs, but self-directed learning is actually kind of a subset, and it comes from the self-determination theory. You provide feedback and positive reinforcement, there's another word that we've seen before, to the patient in real time to keep them on task and to drive that intrinsic motivation to stay on their rehab program or whatever the task that they're doing. So self-directed learning is going to get us to that right-hand side of intrinsic motivation and being autonomous. We're going to use this to get them to that end of the spectrum. Why is it important? We want them to have a lot of self-management, and we want them to focus, and we want them to comply with the tasks that we're asking them to do. And the tasks we are asking them to do is because we want them to get healthy. We want them to return to play. We want them to be productive citizens in the world. And yet again, those are aligned with their goals, what they want to do. So the research has shown that self-directed learning helps us get there. It makes them get to that far end of the spectrum. So, example. Let's go back to here to the flow sheet. So instead of giving little Johnny a flow sheet, we know for his ankle sprain, we want to do, I don't know, 7, 8 exercises, just routine exercises that we would do with any ankle sprain, range of motion, whatever it may be. So you have a spreadsheet maybe for your own use, and you ask Johnny, you know, do you want to use a tongue depressor, whatever it may be. So he tells you, I want to use a tongue depressor for all my exercise sticks, whatever he wants to call them. So what you do is walk Johnny through the exercise you want to do. And the exercise we want to do now is a straight leg raise. So we just demonstrate it and have Johnny complete it. Take him through it safely using key terms, key words, maybe single dosed words like straight leg to the knee, or like a single sentence or phrase. Yet again, having that single dosed feedback. Then have Johnny teach it back to you. Having those same key terms or key words, or if Johnny has a word of his own saying, this is my stop point, let him use stop point. If that's what he's going to know to remember the exercise, let him do it. Then ask the patient what they want to name the exercise, because for our medical notes, it's going to be straight leg raise or whatever the technical term is, but Johnny doesn't understand straight leg raise maybe, or can't identify with that. He wants to name it Frankenstein. So we're going to call it a Frankenstein. So yet again, self-directed learning, doing a teach back, explaining the exercise, doing a teach back, writing it on your thing, on your popsicle stick, having them name it. It's a pretty easy demonstration, but that's literally the entire concept. So every time Johnny comes in, he's going to be intrinsically motivated because he knows what a Frankenstein is. He knows how to do it, makes him confident. And then he's going to be autonomous because he knows he can go over there in the corner by himself and he can do it perfectly. So that solves your problem. You don't have to monitor Johnny. It's something that he can't hurt himself with. He knows how to do it correctly. Does that make sense? So we want that autonomy phase, and that's how you get it. Here's another piece of the self-directed learning is self-regulation. And this basically means that to be able to control and restrain your impulses in order to attain your goals. And this is important because we know people with ADHD have uncontrollable impulses that sometimes that they can't control what they're doing, or the thoughts that come out of their mouths, or they can't shut up, whatever it may be. But having self-regulation will help control them in the athletic training environment and adhere to their exercise program. So self-determination theory complements self-regulation. So self-regulation means that they have to reject the distraction, which is them controlling their focus. So if, give an example earlier, if someone's in an exercise class, so if Johnny's on the exercise bike warming up and then he sees 3 other rowdy athletes come into the room, Johnny's gonna say, okay, all these kids came into the room, I know that they're there, but guess what, I'm focusing, I have to do 5 minutes on the bike. He's rejecting the distraction and saying, I need to focus on what I need to do because my popsicle stick is in my hand. My focus is focused on the popsicle stick that I have. And if the patient displays amotivation or they're not motivated whatsoever, if they're having a really, really bad day, they don't self-regulate at all. So if Johnny comes in, he's really down, he's not focused, and he just doesn't want to be there, that's the time where an athletic trainer needs to have that conversation about, talk to me, what's going on? Because if they're not motivated, they're not going to be focused, they don't want to be there, they're not going to have the ability to reject any distraction. They're just going to be all over the place. So having someone that's amotivated do their rehab, is it really productive for your end or that end or their end? Probably not. So that's why sometimes having those one-on-one conversations in a quiet space with no one else around is very important, because they could be very candid with you about, I'm having a really bad day, or you know, my depression is really bad, whatever it may be. That's very important to have those conversations. Example, you gave little Johnny a task on his wonderful popsicle stick, and Johnny's over there in the corner doing his Frankensteins, not straight leg raises, Frankensteins. And you see Johnny over there, you told him to do 30. Hey Johnny, how's it going? Oh, good, good. How many are you on? 16. Awesome, great job, keep it up, buddy, over halfway done. Who knows if they're on 16, I don't know, unless you're counting from afar. But by just giving that verbal reminder of, hey Johnny, I'm still watching you and I'm still here. I'm giving you your space to be in charge of your own destiny. But having just that simple check-in reinforces that I need to stay focused. Beth is watching me. And if I'm not doing it correctly, she may come over and take that autonomy away from me. But I want to be autonomous. I want to do my things on my own. So even just having a gentle verbal reminder of saying, hey, I'm still here, that can mean the world of difference for them being autonomous or not, and self-regulating. So self-regulating seems like a big fancy term, but it literally is just saying, hey, what exercise are you on? What are you doing? How are you feeling? That make sense? Okay, I know it can be kind of weird. So we can smack that easy button. All right, we kind of talked about this before, but missed and underdiagnosed ADHD is actually a really big deal, because this didn't really come on the scenes until the 1990s. And that's when people with ADD, ADHD, anxiety, or even other sensory deficits that are also on the autism spectrum, that's when your IEPs, your individualized education programs, occupational therapy came into the picture. That's when this all began. And so it's very important for us to know that if we have a patient, especially if they're a freshman in college or whatever, like we've already said, they may get to college and have no idea that they have this disorder, but it's up to us to be aware of it. And so what does this mean for college athletes? They can really struggle in college, because maybe in high school, maybe the classes weren't as hard, or maybe they had a tighter support network. But when they get in college, they may not know anyone in their class. So they're not sitting next to their best friend that can help them out with the notes or whatever. But if they're having academic struggles, that can make them ineligible to play. It can also serve as remediation. So if they maybe fail a class, or if they have academic misconduct, loss of scholarship, that's also a big one that we may or may not know about sometimes in athletic training, but it does happen. And even expulsion. And yet again, this point kind of goes back to the ADHD prisoner studies. Why do you think they were expelled? Was it because of their behaviors? Was it because they were just you know, not following directions, or did they do something really, really, really egregious, or were they given 3 strikes and now they're out? So yet again, sometimes missed and underdiagnosed ADHD leads to all of these other things. So they may not be the troublemakers, the rebellious college kids. They just literally might have a disease that hasn't been treated. So it's just important to be aware of that. Okay, so here comes the question with the NCAA. They came out with a best practices document back in November of last year, and it has 2 key points. So the first key point is that at pre-participation physicals, athletic trainers and team physicians need to screen for ADHD if they haven't been already. And this is a great way to catch those patients that haven't been diagnosed or haven't been on the radar yet. And at this PPE or pre-participation physical exam, you can generate a referral. You can talk to your team doctor. Your team doctor can refer them to a psychologist or psychiatrist. Maybe they might need some academic accommodation. So even in college, they might need an IEP. And if they had one in high school, they can even have it in college. But yet again, things have to be documented from the medical side in order for them to have those accommodations. So if an athletic trainer isn't aware of that and raising some of these flags and pushing some of these referrals, that's not going to happen for that patient. And if you need a screening tool, the NCAA in that document, you can Google it. It's free. In Appendix A, it actually has a screening tool for the physicians. But yet again, in order to get a confirmed diagnosis, they have to use that screening tool for about 6 months. So that's why if you can do this day 1 of preseason, it's the best deal. Instead of waiting and waiting and waiting, just go ahead and start that screening tool. And number 2, promoting a health environment that is supportive of the athlete's well-being and resilience. This comes where the coach can have a huge impact, as well as the teammates can play an important role, or the roommates, or whoever it is. But the coach and the athletes need to support their peers with ADHD, and being aware that if Johnny needs even practice accommodations to make sure that he's doing the drills correctly, or even in the athletic training facility, if Johnny has his own special rehab time or rehab space, don't be taking Johnny at 11:30 when all of his other lacrosse buddies or whoever, what team he's on, is at lunch saying, hey, why aren't you at lunch? They know that that's his rehab time. Leave him alone. They can be very respectful or even supportive. So if Johnny is at lunch at 11:30, they can say, Johnny, isn't this your rehab time? Buddy, you got to go. They can be supportive of that. Even the awareness of the symptoms and being willing to accept that they may not act the same as their peers, but it doesn't mean that they're not capable or they can't be great people. So accepting them into your environment and accepting them for their quirkiness, but I promise they probably do have a sense of humor, and yet again, they're very brilliant. So they're probably actually maybe like making jokes at you that we probably just aren't getting. Yeah, they're very, very nice people and great people. But it's very important to know, if you read that document, the last bullet point on the slide is also very important, that all of these elements that the NCAA is saying that we need to do in our athletic training facilities are literally the difference model. So yet again, how we as an athletic training community could be an agent of change for our patients, rather than saying something is wrong with them. We can say, okay, there's something wrong with them, how can we help? The NCAA wants to help, and they're encouraging coaches, they're encouraging players, everyone to come to the team and say, you know, we all have to be in this together, because yet again, mental health is a very important issue in college, especially at the colleges in Boston. We know that mental health issues run rampant, and this is one of their big pushes to make sure that our patients are getting the mental health that they need, so they do not have mental health and personal issues arise. Limitations, there are a lot of them, not gonna lie. By any means, this study is perfect, but just knowing that athletic training facilities, every single one of them is gonna be different. We already talked about staffing, resources, time, you name it. There's probably a lot of other things on here that I'm not even aware of, but there are definitely limitations to be able to do anything. These recommendations are not universal. Huge. We're very aware of that. Kelly and I both were like, there's probably a lot of loopholes in this that, the recommendations we're making may not even hit the dartboard. And that's okay. That's definitely a limitation. But just know that this is a guide. This is a tool. You don't have to use this tool with every patient, but it's a starting place. And if this tool does not help you, talk to your team physician, talk to your school nurse, talk to your doctors. They're the ones that can help you. We only searched 3 databases. To be quite honest, I didn't have a lot of time to search even more, but we did find a lot of duplicates too. So that's why when we search 3 databases, it does lead to potential bias. There could be other literature out there that we just didn't see. We're very aware of that, but to have over 12, we had 1,241 publications that we reviewed. We feel like that's a pretty good sample size. And yet again, I was the only reviewer. Kelly did help, but yet again, reviewer bias is always a big issue with systematic reviews. So the big conclusions here, caring for these patients is hard. It's time consuming. It is not easy by any means. What do we need to do? Yet again, we went over the 5 pieces. We need to coach them and encourage them. We have to have patient-centered routines that revolves around their goals, their time, their disorder, and their symptoms. It's about them. It's not about us. Single-tiered tasks and simple tasks. Don't make them very complex. Start small and build upon those tasks. Tailor your feedback and reinforce those goals and the behaviors that you want them to display. And make sure that you have an environment that's fixated around them and that's controlled. And yet again, a lot of days, our environment in the athletic training room is not controlled. Things happen. So it's hard, but it's something that we need to consider. And this last point, we may not think about this a lot in athletic training, but accommodating ADHD patients will not only make sure that they have high healthcare quality, this is also about equity. Equity is a huge issue for public health to make sure that people have access to the health care that they need. That's actually a huge topic right now in our federal guidelines with a lot of changes that may or may not be happening with our big healthcare system in the United States. But making sure that if these patients have access to high quality healthcare that we're providing, don't they deserve the same respect and the same treatment as any person in an emergency department that has an autism spectrum disorder? This is about equal care. And if we have a patient that may not have one of these disorders and they're getting the top-notch A+ line of healthcare, shouldn't every single one of our patients be seeing the same thing? It may mean that one patient, little Johnny, might need about 110% of our time, when maybe little Lizzie over here might need 10% of our time. But I think that Lizzie and Johnny should be treated the exact same. And just because Johnny has ADHD, that doesn't mean that he's any different. He's not a defect. He's a person. And I think this is really an equity issue, if anything. And if our profession is saying that we are patient-centered, that's become our new saying for the NATA, we're a patient-centered thing. We better be putting our money where our mouth is. We better be treating the patients that are in front of us, regardless of the baggage that they have or the symptoms that they have. It's no different. We need to be treating every single one the same. Last notes. I'm going to read these verbatim. Some of them we already hit on, but I think they're very important. This came directly verbatim from the publication that we wrote. It can be easy to reprimand a patient for inappropriate behaviors and non-compliance, but difficult to acknowledge and accept unproductive and disruptive behaviors as a norm within our social, medical, academic, and athletic environment. So if Johnny's acting out today, that's a norm. That's okay. Accepting him and not pushing away. ATs play an important role in the physical, psychological, and emotional health of our ADHD patients. And sometimes we may be the only health care providers that they have. So it's very important that that we're just aware that we may be it. There is no primary care doctor. There is no other people in their lives that care about them. That could be a very, very real possibility. Be quick to help and slow to judge. Put yourself in their shoes and find a way to make your athletic training practices fit the needs of every single patient. Not easy, not hard. It may take some time for us to come to that realization. I think it took me at least 9 months to humble myself enough, saying, guess what, I'm not being a good health care provider, and I honestly don't know what to do to help my patient. So I need to stick myself in their shoes and figure out how the brain is processing what I'm saying. And I need to remove myself and my judgments from the situation. It's hard. It's not easy. ADHD isn't one size fits all. I think we've discussed that. There's a whole spectrum. People are always going to be different. Every day they're going to be different. So it's going to be tough. It's going to be easy, but I think our athletic training profession, we're MacGyvers. We like tough situations. We make beautiful things out of not so beautiful situations. That's the glory about our profession. I do have a lot of references, and this is not an exhaustive list. Everything is actually in the article online. But do we have any questions? I know we had some great ones earlier. Do we have anything online?
Not yet, but they probably have more time to
Okay, keep the questions coming, and I like this, the little cat. Thank you. Thank you. Go ahead.
Maybe not so much like a question, but like in a general kind of sense. So I know you mentioned a lot about like the ADHD and the ADD, and you also kind of touched on like autism and like that spectrum. With the DSM-5 and the changes that they made to the DSM-6 and the whole thing with like labeling, you know these kids have ADHD, you know these kids have ADD because they've been like labeled.
Yeah.
Well, the kids with Asperger's and autism, you have to fall under a certain like, you have to have certain 3 points under like the autistic scale to be considered autistic, and if you're not, you have to meet the Asperger's, and if you don't, what are you? So you're not necessarily labeling them as having a disability. So how do you even go about that? It's like, how do you can't treat something you don't know what it is. Yeah. So it's like you can't tailor their exercise, but you can't be like, oh, well, they have trouble listening, they have trouble with this. You really kind of have to like figure them out and know them. Like you have to know them as patients as opposed to like, oh, okay, they have ADHD, they have Asperger's, they have this. You can't like put them in a category if they're not already in a category. You have to like make your own.
We had a very
even if somebody has, you take 5 people with the same diagnosis, they can present very differently, regardless. Yeah. So athletic trainers are so good about knowing their athletes out of a lot of healthcare professionals. So
So for the people online, we have really good comment / question. So for Asperger's and autism, they also have their own clarifications and qualifications. And if we have a patient that may or may not fit those, you know, how are we supposed to treat them when we don't know what check boxes that they checked off for those disorders? And that's a very good question. And we kind of had a nice dialogue back and forth about, you know, every patient may present differently. They might be diagnosed with the same thing, but from my experiences, my mother was a school teacher for 38 years, and it got to the end of her career where school teachers weren't allowed to say, I think your son or daughter has ADD, ADHD, whatever it is. They can suggest to the parent, I'm seeing these behaviors in your child. Maybe you can go to a doctor and have them have a further look. So I think that's kind of what you're hinting at, that we may see these behaviors and maybe they have or have not been diagnosed, or if they have been diagnosed, sometimes we may not know the exact check boxes that they checked off for Asperger's or you know, autism. But that may actually, if you do have a patient with Asperger's, autism, there's one of those more severe autistic you know, disorders, we as athletic trainers, I mean, should we be asking for that paperwork to say, can you let me know exactly what symptoms your son or daughter has? That may be, I wouldn't say breaching privacy, but we kind of have to, right?
Utilize the resources that you have available at your institution. Your guidance department, in case of high school or college health services, psych counseling services, things like that. Utilize them because they're the ones that handle it. If you have a question about a kid, or it's best for you not to necessarily directly approach a parent about it, but to go through that channel to say that, hey, the guidance counselor, Jesus, Johnny's got something going on here. You know, maybe you want to address it with his parents. This is what I've seen.
Yes, we had a good comment for those online. That utilizing your resources, such as a guidance counselor or someone else in your school to say, hey, Johnny is struggling with this, and then maybe the guidance counselor or someone else can bring it to the parents. That's good. Good note. We got another.
2 webinar questions.
Yep.
How do you suggest athletic trainers deal with an athletic director that thinks dealing with ADHD issues are out of our scope of practice, and that our athletes are not patients, they're just athletes?
Oh, that is an extremely awesome question. Oh, wow. So in regards to the athletic director, my recommendation is print off that mental health guideline from the NCAA, because there are actually a lot of other points on that document that could help address that question. But even I think the American, the ACCSM, the American College of Sports Medicine, maybe some other resources to see if there's maybe a tip sheet for not only parents and coaches about maybe their patient's diagnosis or their symptoms and how they may behave. But what was the second half of that question? I'm sorry.
So she asked, how do you suggest athletic trainers deal with an athletic director that thinks that dealing with ADHD issues are out of their scope of practice, and that our athletes are not patients, they are just athletes?
Okay, I got you. So my question to an athletic director that does not think that they are patients, it kind of goes back to, we have someone here that works in primary care. If you or your athletic director sprains your ankle and goes to your primary care doctor, they become a patient. But if that same exact ankle sprain and they come to you as an athletic trainer and you are providing healthcare, we are licensed credentials healthcare providers, why is this person not a patient? It's literally the same exact ankle sprain, the same exact patient. The facility may be different that we're seeing them, but they're still a patient. And if they're going to have to be referred for care or something else, they're still going to be classified as a patient. So we as healthcare providers, I believe in my practices, everyone is a patient, regardless of how minor or major the injury is. They're still going to need healthcare services that we're providing, so that puts them into the patient category. They may be an athlete or athletic director in their title or their label in the world, but all of us at some point in time in our lives are always patients.
I haven't encountered this, but do athletic trainers usually have access to IEPs?
No.
As a comment from an online.
IEPs, I'm hearing no.
So I'm in a high school world, and I'm contracted out from hospital to high school, and they don't want to share that to me. So it's only if a parent might want to share something, or the kid might share.
It's
But
independent to your setting completely.
yeah.
Okay, so
So not always have access to
Everything.
IEPs.
But you're
complete
right.
contract.
You're as a contractor.
Yes.
Yeah. So again.
Yeah, it's so individual, it's crazy.
So the question about the IEPs, we're having a nice dialogue here that some places may not have access, but some places they may. So it might be setting specific, or whoever you work for. It may depend if you have access to that information, because yet again, it's FERPA, but then we have HIPAA. So yeah, FERPA trumps HIPAA. So yeah, it's a great question. I think it's setting specific. We got another question?
I actually have a question.
Yeah.
How would you recommend dealing with sideline concussion evaluations when you may or may not know that a patient has ADD, ADHD, ASD, so on and so forth?
That's a great question. For those online that couldn't hear, so if you are doing a sideline concussion assessment and you are unaware that a patient has ADD, ADHD, autism spectrum, one of the disorders on that spectrum, how do you go about that? My advice from my own personal practices, and I think maybe some other physicians may or may not agree, but I would still evaluate them as is, and then refer them to the physician, and their physician should know if this symptom is normal or not, because they already probably have a baseline, because yet again, to be diagnosed with that, they have to have 6 months of diagnosed behavior. So I would say do your evaluation as normal, document it, and then leave the rest up to the physician, especially if later on if they mention, oh yeah, I have ADHD, because maybe one of the questions you ask in your evaluations, are you on any medications? And they say, oh yeah, I'm on Adderall. Huge flag.
Yeah.
So because that's one of the medications.
I know I usually ask before I even start an evaluation if they have
Yeah, any medications.
any
Yeah.
medications, or if they have ADHD
Yeah.
or ADD.
Yeah, but yet again, treat the patient in front of you, and if they're showing the red signs and red flags of they need to see emergent care for a concussion, then absolutely do it. But document everything, and we can go from there. So we had another hand. Yeah, go ahead.
Okay, so the other thing that I have found is that some people can be on medications that cause symptoms similar to ADHD.
Mm-hmm.
So this goes kind of back to some of our points too, where I feel like it's similar to athletic training in general. Some injuries, no matter if you know something is broken or not, you're going to do the same management of that injury. So I think of it the same way, that regardless if you know for sure certain diagnoses or not, or have access to that to confirm or not, if you're picking up on certain things, then you're going to want input from your patient to say, oh, is this environment okay? Or, you're still going to check in with them. Same sort of thing that you would do with a normal injury, right? Whether or not you have a specific diagnosis yet for certain things. It's the same management. We used to debate about that all the time in athletic training. Well, we're going to still do the same management plan, regardless of exactly what this is or not, that sort of thing, until you know the diagnosis. The other thing that I want to offer is...
Can I give an update for those online? So update, we just had a great comment about those with that may be on medications for some of these, talking about sometimes they can actually have symptoms of ADD, ADHD. They can cause other medications in general can of these disorders. So it's just good to be aware of that, and maybe having a conversation not only with the patient and maybe a physician or whoever it is to say, okay, this is their baseline, but these are also side effects of some other medications that they need for something else that they're dealing with.
Anti-seizure meds.
Anti-seizure.
I've seen a lot of that cause very similar sort of things as ADHD.
Great.
The other thing I wanted to offer, and some of these I think could be obvious, some of these might not be, so I just offer them in addition to some of the things that you pointed out that were really great suggestions. Some people are mild enough that just having their back to everything else going on is enough to shut them off from everything else going on. Having them bring in their headphones and music shuts them off enough to everything else going on that helps them just focus on their music, especially like autism. Focusing on their music, getting in their zone helps them. The other thing I've done, if they're doing exercises facing a wall or something, putting a tape mark on the wall and saying, like, this is sort of focal point. And it helps them just direct their attention that way and keep them on point instead of trailing off. It's like just one of those cues. I dealt with a lot of visual and tactile cues for a lot of my patients. And it's really, but again, it's checking in with somebody saying, hey, would this be helpful? Or do you want to just throw some tape on there and see if that helps you? And even for profession athletes and things like that, it helps them too as well. Like I dealt with a lot of TBI.
That's good. So for those online, we just had a great comment about some small modifications depending on the severity of your symptom. Like sometimes just simply having the athlete turn their back to the rest of the room so that they can do the rehab, that might work. Or for people with autism or other, depending on their symptoms, sometimes listening to their own music or having the sound canceling headphones can be huge. Or even putting like a small piece of tape on the wall so that they focus their all their attention to that tape on the wall, and it focuses in that one area.
If you know an athlete has ADHD, is assessed or diagnosed with a concussion, and is having problems with memory and focus, of exercises, when appropriate, would you use to help them with the memory and attention issues?
Ooh, that's a great question online. To be quite honest, there's a lot now with vestibular therapies and more advanced concussion things. If they're already having a lot of memory problems, I would defer that back to a physician to make sure that that's normal. The question was, if you have an athlete that is just consistently, persistently amotivated, what point do you draw the line to say that, that's it? From what I have seen, amotivation is because something else is going on. So sometimes if you treat, either it be depression, anxiety, they failed their exam, their home life is horrible, there's something causing that amotivation. It may be something within their brain, a chemical imbalance, or it may be something in their external world that won't let them get to external motivation, because the external motivation is so bad, they're gonna stay in their hole. They don't. So having that one-on-one conversation, but if you do have counseling services or a guidance counselor, I think that is, you have to get down to the bottom of the issue, why they are not motivated. And a lot of times, I wouldn't say it's not outside of our scope of practice, because we are great listeners. We're not counselors, but listening sometimes is a great counseling thing that we can always do. And if they can trust us with personal things, to be really honest about what's going on in their life, which I hope they are, especially if they have other mental health issues going on, it's very important that they're open with us about their stuff. I would utilize counseling services, maybe a coach, because I know some of the coaches, especially where I have worked at, did have degrees in counseling. Or if you're at a college and university, they do have student health counseling services. Some places might be lucky enough to have a sports psychologist that is also a licensed mental health counselor. So I think for an athletic trainer, it's important to notice that. But if they are consistently just not motivated and you're like, you're just not okay, like what's going on, I would gently refer them to elsewhere to see if you can get down to the bottom of it. Because I can be long-winded, but I actually know of an athlete that was amotivated, that wanted to quit their sport. It wasn't necessarily ADHD that was the problem. They were not ADHD at all. It was because they had a huge conflict with the coach, and they said, I just can't. I'm going to quit. I'm going to give up my scholarship. I'm done. And the reason for their amotivation was because the person that they had to deal with every day, they could not see head to head. And that person ended up having to take a leave from their sport to get counseling. But then they also, not only did they have to do counseling, they brought in the coach, and the coach was completely oblivious that this athlete was having such a big issue with them. So it's kind of weird that the athletic trainer sometimes may have to facilitate that, but it's also good to know what's going on in the periphery, because that may also explain their symptoms or their behaviors. So I think that's a great question. Sorry, I just spoke a novel. I'm not giving single-tiered feedback to you. I'm going against my word. These are all great. This is awesome. Any others? Comments, jokes, anything? I think that's it. Thank you. Appreciate it.
Thank you so much, Beth. That was amazing. We really appreciate your time.